Selanjutnya, mungkin kita bisa lanjut ke materi yang kedua. Untuk materi yang kedua nanti disampaikan dalam bahasa Inggris. Apabila ada yang mau ditanyakan, boleh nanti di kolom chat. Saya juga bisa bantu kalau memang ada yang belum clear, nanti bisa info. Nanti kita coba bantu untuk subtitlenya ya. Kita coba. Okay, I think Dr. Khaja Javed Khan, thank you so much for joining us. Dr. Khaja joining from India, Mumbai. Okay, this is the resume slide. Dr. Khaja Javed Khan. He is a doctor of medicines, graduated from GSS Academy of Higher Education and Research in India. He also graduated pain medicine from New Horizon Public School in India. And then he also got the fellow in pain management in 2019-2020. This is the pain certification from India, from Daradia Pain Hospital. And then he also taking the pain management certifications from Belgium, Europe, EDPM, EFIC. And then similar with Dr. Eka, also joining the fellow international pain physician from United States of America, World Institute of Pain. Currently, Dr. Khaja Javed Khan is director and also consultant in Algos Multi-Speciality Pain Clinic. So he owned a pain clinic in India. He also owned the pain medical school in India. He also a consultant and head interventional pain and also palliative medicines in Sitekare Hospital in India. Until December 2023, Dr. Khaja is consultant pain and palliative care physician in Fortis Healthcare in India. So basically, Dr. Javed already did working with pain management and also palliative care since 2020. Dr. Khaja, are you there?
Hi.
It's all good? The patient is good?
Yeah, patient is good. Patient is good.
Okay. Shall we start now?
Yes, we can start.
Okay. Good morning, Dr. Khaja. How are you?
I am very well. Very good morning, Carli. Good to
Long time no
connect you
see.
again. Very long time. Very long time.
Very long
Last
time.
time,
Thank you so much,
last time
Dr.
we were
Khaja.
met in person. Now we are seeing virtual. So it's a happy thing. Very
Right.
happy at the outset. Thank you to Medicore Training and Institute and Carli and everyone for extending this warm invitation for me to deliver a talk on a very important topic of radio frequency ablation.
We are. Thank you so much. I'm so honored. Thank you for your support all these years. Hopefully, more pain practitioners will join. Right now, we are having some anesthesiologists, neurologists, medical rehab, orthopedics, neurosurgeons are joining in this event, and also the GP is also joining in this sessions.
Okay.
Hopefully, we can learn from you. We can refer the patients. We can give the answer because we are as a GP. I personally, we are coming as the first gate for all the patients coming to us asking anything, and we really hope we can give them some options, the new options, the mild in pain interventions to increase the quality of life for our patients. So thank you so much, Dr. Khaja, for joining us. The screen is yours. I already explained to all the practitioners here that you are most likely since 2020 already practice pain physician and also palliative physicians. You are graduated from India and also have so many fellowships from Europe, United States, and Indian, and so on and so forth. So we would like to welcome you. Thank you so much for joining and eagerly to learn from you. Thank you so much, Doctor. Screen is yours.
Thank you. Can I start sharing my screen?
Exactly. Sure.
Yeah. Is my screen visible? Kindly confirm.
Perfect.
Okay. So at the outset, before I begin, thank you very much to Medicore Training Center for extending a warm invitation to me. I represent Algos Academy of Medicine. I am Dr. Khaja Javed Khan, and it's always an honor and pleasure to talk to all of you and share my experiences. Today's topic is radiofrequency ablation in the knee joint, and I think the previous lecture was about basics of radiofrequency ablation. Wonderful lecture. So I'd like to congratulate them and extend more on the topic of radiofrequency ablation in the knee joint. My slides are moving. Yeah. Okay. So coming to today's presentation, this will be the overview of today's talk. We shall start with a brief introduction and then go into a little bit of basics of radiofrequency ablation. We shall focus on the targets of radiofrequency ablation and fluoroscopy and the ultrasound guided technique. So there have been a lot of changes, a lot of advances in the technique per se of radiofrequency ablation, most of them to help improve the chances of success. We will be addressing that, and finally we shall conclude. So, whenever you have a patient with knee pain in your OPD practice, you see that patient comes with pain and swelling in the knee joint region. Whenever they are above 50 years of age, it indicates that knee osteoarthritis could be a common cause. And it has quite a high incidence. In this part of the world, it has an incidence of 45% almost, 40 to 50%. So that indicates 1 in 2 patients suffer from knee osteoarthritis. That's how high the incidence of osteoarthritis is. And radiofrequency per se, the technology has emerged as a benchmark in the field of pain management. So coming to radiofrequency ablation, well, remember, radiofrequency ablation is a non-surgical, minimally invasive procedure, which uses heat energy to stop the transmission of pain. Okay. So basically, to make things more simpler, radiofrequency waves ablate or burn the nerve that is causing the pain, essentially eliminating the transmission of pain signals to the brain. Now, there are different kinds of radiofrequency ablation. I think we've already seen there are two major types: conventional radiofrequency ablation, the pulse radiofrequency ablation, right? Conventional or standard RF, okay, is there. So the amount of tissue ablated is not that much. It is a certain size, whereas cool radiofrequency ablation is a slightly larger size lesion. Whereas in cool radiofrequency ablation, the size is large, but the temperature used is low. It's 60 degrees. The time is 2.5 minutes for cool radiofrequency ablation. Whereas for conventional or standard RF, it is 80 degree centigrade almost, and duration being up to 1.5 minutes or 90 seconds. The volume of tissue heated and the resultant thermal lesion is substantially larger with a cool radiofrequency ablation. What is the principle of the cool radiofrequency ablation? Well, in contrast to the conventional RF, where I mentioned the parameters are 80 degrees Celsius for 90 seconds, the cooled RFA uses a constant flow of ambient water that circulates through the electrode through a peristaltic pump, which maintains a lower tissue temperature by creating a heat sink, but still allowing neurolysis to occur. By removing the heat from the tissues immediately adjacent to the electrode tip, the lesioning temperature is maintained. So there is less tissue charring adjacent to the electrode and less tissue impedance. This is a comparison between a standard and a cooled RF. Okay, so we have a conventional monopolar radiofrequency lesion compared to a cooled RFA. So remember, with a standard RF, we call it as a candle flame. The lesion looks like that, whereas with a cooled RFA, it's more of a spherical lesion. Okay. So both of them work through ionic heating produced by friction of the charged particles, okay, which creates heat. And therefore, thermal ablation occurs and deactivation of nerves occurs that are responsible for carrying the pain signals. Remember, whenever you are doing the standard RF, especially for a knee, a chronic knee pain, you need to be exactly on target. If not, what happens is certain nerves can get missed because there can be variation. Okay, because we follow the landmark guided techniques. Okay, and because of this, what happens is we need to be very careful. And standard RF might not be able to capture all the nerves in one single attempt. You might need a cooled RF, for example, to capture all the nerves with one single attempt. The ionic heating in a standard RF is greatest at the probe and tissue interface. You can see it's 80 degrees centigrade in the picture, and lesion occurs only within the area immediately adjacent to the probe. The lesion distally projects at a minimal distance beyond the tip, resulting in an elliptical shape. Diameter of the lesion in conventional RFA is about 4 millimeters. So therefore, because of its shape, size, and lack of distal projection, standard RFA lesions are too small to reach all the targeted nerves. Okay, so this is a picture of the standard radiofrequency probe. Hope it's visible. You have the outer insulation, you have the cannula, and you have the radiofrequency probe. And remember, the active tip is where the lesion is actually occurring. You can see the lesion area in that elliptical fashion where it is happening. So this is a comparison again between standard and cooled RF. Cooled RF, larger volume, greater distal projection, and enables angle independence. This is how a cooled RFA probe looks like, okay? So it's a water-cooled probe. The moving fluid acts as a heat sink, okay? Removing the heat away from where the tip and tissue are going to interface, okay? And by delivering RF energy through water-cooled electrodes, greater RF energy can be safely transmitted to the nervous tissue. So here you can see, okay, this is the cooled RFA probe. All right, you can see outer insulation is there, and you have the active tip and radio frequency probe. But look at the water. The cool water is circulating. Remember, many people get confused whether cooled RFA is actually cryoablation. Both are totally different. It's called cooled RFA, but still the temperature is still high. It's 60 degrees centigrade, right, for the lesion to occur. Whereas cryoablation is more for freezing temperatures. That's also for neurolysis, but again, that's a totally different topic. So can you see the lesion area in a cooled RFA? It is a larger lesion area. This is how it looks. Okay, you can see that there is 5 times larger volume, 45% distal projection or greater, and angle independence. And you can see that the lesion size is almost 3 times that of the standard RFA probe. Clear till here? So we have addressed the different a bit of rebrushed, I would say, rebrushed a bit of basics. Now let's go to the cooled RF, the radio frequency ablation of knee pain for chronic pain. Remember, the knee joint as such is innervated by articular branches called as genicular nerves, right? So would be the femoral, tibial, common peroneal, saphenous, etc., right? And always the dictum is the articular branches are going to follow the genicular vessels. This is an innovation of the knee joint capsule, what you're seeing. So we have the important nerves. Important nerves are superior medial genicular nerve, superior lateral genicular nerve, inferior medial genicular nerve. Okay. Other nerves are also there that include nerve 2, vastus intermedius, vastus lateralis, vastus medialis. Saphenous nerve branches are also there, especially the IPBSN. Now, IPBSN is infrapatellar branch of saphenous nerve, a very important one. You can have a look. That is one which takes the innervation from the medial side of the knee joint capsule. So whenever you are seeing over here, just annotating this a bit, so you can identify more well. Okay, so this one is very important, the IPBSN, infrapatellar branch of saphenous nerve. Can you see this innervation? This innervation. This is very important. This is the medial joint capsule innervation, okay, which many of a time was being missed, not being covered, but now if it is covered, then it gives very good effects and relief for the patients. Okay. And what happens is whenever these are done, it takes away the pain of the medial joint line, because medial joint line is where the maximum pain occurs, right? In most of the patients with varus deformity in osteoarthritis. Here again, you can see a bit more closer view. Superior-medial genicular nerve, inferior-medial genicular nerve, superior-lateral genicular nerve, superior-lateral genicular nerve. Common fibular nerve and nerve to vastus lateralis take from the lateral side innervation, okay? And the recurrent fibular nerve is more in the inferior and lateral aspect of innervation. Let's move ahead to the targets now. Targets, well, initially, these were the targets: superior medial genicular nerve, superior lateral genicular nerve, and inferior medial genicular nerve. And suprapatellar genicular nerve was the optional fourth lesion. Superior medial genicular nerve, okay. Remember, we told the nerves are going to follow the vessels, right? So we are going to target this with an ultrasound, okay. So when you do with an ultrasound, you can see just at the junction of the shaft and the condyle on the medial side of the femur, you can see a superior medial genicular artery pulsating. Okay, just close to that, you have to target the lesion. Superior lateral genicular nerve, again, lateral aspect, junction of shaft and condyle, you're going to see the artery pulsating, and that's going to be the target. Now, inferior middle genicular nerve, middle aspect of tibia, shaft and condyle junction, you can see the inferior middle genicular artery. So these were the previous ones, okay, as I told, but now, as I said, these were challenged because they were being done fluoroscopically, okay. So a study came which actually challenged it. So this is an article by Loic Fonco et al., wherein the accuracy of fluoroscopic genicular nerve blocks a need for revisiting anatomical landmarks. This article reported this was more of a cadaveric study, okay. And what we understood from here is that what were our initial targets? I told you. I told you junction of shaft and condyle. Am I right? So these were the initial targets. Look at the needle here, right? But as per the cadaveric studies, it was found out that the superior middle genicular nerve is more towards the adductor tubercle. Can you see this? Similar with superior lateral. Inferior medial was almost similar. This is the AP target, but when you go posterior, we were stopping the needle over here. But you are seeing the target was more posterior. So this kind of explains why there were failure rates occurring with knee radiofrequency ablation, because the targets were not accurate. Are you seeing how much of a difference is there? Needle is there, but the target is here. This much of a gap. Needle is there, target is here. This much of a gap. Okay. So now the study confirmed that the anatomical landmarks needed to be revised. Okay. So after that, now we have the changes. Now superior medial genicular nerve. So earlier thought to be where the red point is. That is junction of shaft and condyle. But now focus on the star. That is the adductor tubercle. Can you see the adductor tubercle over here? This is going to be the adductor tubercle. Okay. Here is where the target is. All right. Let's have a look at this now. Superior middle genicular nerve, we do an ultrasound scanning, okay? Keep the ultrasound probe same at the junction of shaft and condyle, translate a bit below and posterior. You're going to find the adductor tubercle. Now, AT, what you're seeing is the adductor tubercle in the picture. So you have to put in the needle close to the adductor tubercle, and that is where you're going to lesion the superior medial genicular nerve. Okay, this is going to be the targets. So first you're going to scan it and then place the needle out of plane, then rotate the transducer and then advance the needle in plane towards the adductor tubercle. Okay, now this was about superior genicular nerve. Now remember we were doing the lesion previously. I told you at the junction of shaft and condyle. Well, now that is found to be nothing but middle branch of nerve to vastus intermedius. So again, that lesion also we are still continuing. Okay, so you can see the red and the blue, that is where the difference is there. Coming to inferomedial genicular nerve, well, the target remains the same. Okay, what you were doing before, the same target is there. Junction of shaft and condyle, you can see the junction of shaft and condyle of the tibia. You can identify the genicular vessel, genicular artery, and then advance the needle towards it. This is how you put the needle in first out of plane and then advance it in plane towards the artery. Infrapatellar branch of venous nerve I was showing you is quite very important, taking the medial innervation. Okay, it's also close to the adductor tubercle only, but only thing is it is present subcutaneously. I'll just decipher the nerve for you. Hope you can identify over here. This one is going to be the nerve. Okay, so it is present subcutaneously. So because it is present subcutaneously, we are going to do a pulsed RF for this and not a conventional RF because it is subcutaneous. And if conventional is done, there can be safety concerns. It can damage the skin subcutaneous tissue. That is why we don't do a conventional, but we do a pulsed RF for IPBSN, which is intrapatellar branch of saphenous nerve. Moving ahead to the superolateral genicular nerve. Again, as I said, the landmarks have changed. So we have to go translate a bit below and more posterior. Okay, so here you're going to see the target for the superolateral genicular nerve. Below and more posterior, where you can see the dotted yellow E over there. That is going to be the target. So here again, you're going to see, okay, so we're going to scan and then take the, either you slightly translate the probe and then take the needle in over there, or else fully translate the probe and take the needle in plane towards the femoral shaft at the junction of the lateral cortex and the posterior cortex on the femoral shaft. Well, this is a recurrent fibula now, the last nerve now, okay. Inferolateral pain, if it is there in the knee, that time we are going to target it, okay. But remember one thing, that if this pain is not there, if the patient is not having a pain in the inferolateral region, then we are not going to do this particular lesion. We're just going to continue with the other ones. Okay, so you can see the recurrent fibular nerve and the lesion happening towards it. You can see the junction of tibia and fibula. Do not go too anterior, okay, because you have the common peroneal nerve there and that can get damaged, right? So to put things into perspective, you can see the nerve supply, articular supply to the knee joint is immense. So you cannot target, it's practically impossible to target each and every nerve. So that reason, what we have to do is we are targeting almost 65 to 70% of the nerves. Yeah. Okay. So that was about the nerves. Let me just repeat the nerves again. Superolateral genicular nerve, superomedial genicular nerve, nerve to vastus intermedius, medial and lateral branch. Okay. And then inferomedial genicular nerve, inferolateral genicular nerve, which is a common fibular nerve, and the recurrent fibular nerve. Coming to knee osteoarthritis, well, most common cause for a chronic knee pain, the cartilage, which is there, gets damaged. Okay, cartilage is nothing but a hard, slippery tissue that covers the ends of the bones from where they form a joint, and a wear and tear can occur prolonged over many years, or it can be hastened by joint injury or infection leading to osteoarthritis. Here you can see a comparison between a healthy joint and a osteoarthritic joint, wherein there is exposed bone and the cartilage begins to break down. Fluoroscopic technique was done before. I had started learning with the fluoroscopic technique only. So these were the AP targets and this is the lateral view targets. Okay. This is a fluoroscopy technique, what we were doing. This is I again shifted to totally the ultrasound guided technique. So you can see the conventional RFA, which I am doing the patient. Okay. So this is a video, just play this video. So this is just identifying the genicular vessel, okay, and then putting a Doppler over there. Hope my video is visible. Sorry. Wait. I will see. Hope all of you can see the artery, okay, pulsating artery. This is the cooled RFA. You can see the cooled RF machine in the background, okay. Again, doing the ultrasound guided approach. This is another video, okay. You can see the RFA needle being placed close to the vessel. Okay, so if you look at the literature, the supporting evidence, then this is a systematic review and meta-analysis. So it shows that RFA on the genicular nerves exhibited a more significant and long-lasting analgesic effect. This is again a technological overview of cooled RFA and its effectiveness in management of chronic knee pain by Leonardo Caporal et al. It demonstrated clinical superiority over other modalities, and a majority of patients, more than almost substantial 65%, had pain relief exceeding more than a year. That is quite a good number and a strong number. Now, if you want to compare between ultrasound and fluoroscopy, well, ultrasound has a lot of advantages. One is there is no radiation. It is under real-time guidance. Soft tissue visualization, including effusions, can be seen. The Doppler, as you saw in the video, what I have shown, genicular nerve visualization becomes easier through it. If you can see the vessel pulsating. Less pain to the patient, no need to be in contact with the periosteum. This point is the biggest advantage, okay? Since we have started using the ultrasound as a technique, because fluoroscopy, we have to hit the bone and then slip. So contact with the periosteum used to cause a lot of discomfort and pain to the patients, which now can be avoided because you are using the ultrasound. Minimal usage of sedatives, analgesics, and local anesthetics, and both knees RFA procedure can be done in the same session. One thing what we have to understand is with radiofrequency ablation as such, since it has come into the picture, there have been a lot of advantages. Okay. And as you can see, I have already outlined them. So it is now, I mean, almost like a very good alternative to knee replacement surgery, especially for patients who cannot or don't want to undergo a knee replacement surgery. And if you look at the safety wise, then radiofrequency ablation has a lot of advantages. It is very safe, okay, done under expert hands. Reason being, only local anesthesia is required. You don't want the patient to be either into sedation or GA or anything. Just local anesthesia is sufficient. The RFA procedure as such is again a very simple and safe procedure. Okay. So only thing is you have to know which modality to use when. Okay. So radio frequency needles, which are there, they need to be advanced to the exact target so that as much ablation happens with as much safety to the patient. So to conclude, the cooled RFA lesion covers a larger area. This is what we had learned in the compared to the conventional RFA technique. Ultrasound scores far better over fluoroscopy in the knee pain interventions, especially radiofrequency ablation. But most important thing is multidisciplinary, multimodal approach. Any patient coming to you with knee osteoarthritis will have existing comorbidities as well. For example, they might be obese, there might be weakness of the knee muscles, the quadriceps, the hamstrings, etc. Right? And other thing is there could be other comorbidities as well, diabetes, hypertension, and all that. So what I would emphasize is whenever you are seeing patients, practice to treat the patient as a whole. Do not just look as knee pain as a problem for the patient. You have to picture the patient as a whole. You have to treat the patient as a wholesome being, and multimodal, multidisciplinary targeted approaches should be there. For example, clinical nutrition, clinical psychology, uh, physical therapy, and rehabilitation. All of these also occupy equal amount of importance for you in getting the best results out of your interventions, especially for these patients. With this, I'd like to conclude with a thank you note. Thank you very much for the invitation. So if there are any questions, I'll be more than happy to take them and answer them. Thank you.
Thank you so much, Dr. Javed. There is a questions about contraindication for radiofrequency. Do you have any measures for that, maybe? Concerns,
Yes.
the contraindications?
So contraindications, again, there can be a few contraindications for radiofrequency ablation. We learn to classify contraindications into absolute and relative contraindications. So contraindications, absolute contraindications, of course, would be one thing like, for example, somebody is having terminal illnesses, a cardiac illness, coagulant disorder, wherein even putting in a needle might be very difficult for the patient. These are absolute contraindications. Patient refusal, a patient not wanting to undergo the procedure, not giving consent, is also a contraindication for the patient. Any infection, if there is any infection for at the site where you plan to do the radiofrequency ablation, okay, then that also becomes quite a lot of problem. And the other thing includes, like, if there is any a tumor occupying that particular area where you have to do lesioning, then that also becomes quite a problem. Okay. Relative contraindication again could include something like, excessive pain for the patient, and for example, pregnancy again becomes a relative contraindication. Relative why? Because we can always use the ultrasound as a modality to treat that. Okay. So these are few other contraindications.
Okay, noted. Another questions, if we compare RF therapy with serial injection of hyaluronic acid up to 4 to 5 times, in the case of this articular knee, which clinical result is better? What do you think?
See, intraarticular injection of hyaluronic acid, we have to understand the mechanism, how it is going to act. So when we inject a hyaluronic acid inside the knee joint, then what it is going to do, it's going to produce more of a lubrication inside the knee joint, okay, the joint cartilage and everything. So that will help one, decrease the inflammation a bit, and then improve the lubrication a bit, hence reducing the pain slightly and then improving the mobility. But the problem which happens is longevity. We are not addressing the entire thing. Whereas in radio frequency ablation, we are addressing the nerves. You are blocking the painful nerves around the knee joint. So that helps giving long lasting effects. But to tell you, in my practice, I combine radio frequency ablation with a hyaluronic acid injection as well in many of my patients.
Dr. Tan, what do you think, Dr. Tan Suryo, about the answer? Do you still have uh, more questions maybe related to that? Okay. Any questions? More questions maybe? So do you still think combinations, yeah, multidiscipline approach? Okay, Dr. Tan said it's okay enough for him. Thank you so much, Dr. Khaja. And then how about you got the certifications from Europe and also from US? Is there any big difference from that, doc? Or the certification is quite same, maybe?
So basically, the certifications are different actually. So when we talk of the certification from US, that is World Institute of Pain, right? So we have FIPP and CIPS, that is
Yes,
fluoroscopy,
FIPP.
that is fluoroscopy based exam, FIPP, and CIPS is ultrasound based exam. So these are certifying exams conducted by World Institute of Pain, and basically it tests your expertise. It tests your practical knowledge, how much of expertise you're having with respect to these specific modalities. And this exams again can be attempted almost up to 4 times a year.
4 times a
Okay.
year.
Yeah.
Okay.
So starting with Taiwan first in January, and in the month of April at USA, Florida. and August at Hungary, Budapest, and October at Turkey.
Can GP join that, doc, if it international?
Yes, yes, yes.
Oh,
You
GP
can.
can, ya, doc. GP can.
You're asking about
The
course?
requirements, the requirement. Let's say I'm general practitioner and I would
Yeah.
like to join the course and join the certification. Do you think is it possible?
So basically, they have a information bulletin wherein there is entitled and eligibility criteria. So eligibility criteria, I think, requires some form of post graduation for that, either orthopedics or anesthesiology or physical medicine and rehabilitation. And most important thing is 1 year of practice, 1 to 2 years of practice in the field of pain medicine, wherein you're actively seeing patients and doing procedures.
Oh, GP is okay, but I need 1 year to be practice and already have a record as pain physician. Is
Yes,
that
yes,
correct?
yes. You should be
Oh,
practicing pain
okay.
medicine. This is for the USA, the World Institute of Pain. EDPM again, EDPM does require a post-graduation, and EDPM also requires 1 year of certification. But EDPM, European Diploma in Pain Medicine, it is a two-part exam, part one and part two. Part one is online, usually held in the month of November. So last November 15th was the exam, and part two exam is usually held in the month of September, August, September, wherein the candidates need to travel to Belgium to go and write the examination. So we have preparatory courses for both the FIPP as well as EDPM, and I'm happy to share that this year our FIPP preparatory course we had 100% pass results. All of our candidates who took the exam have successfully cleared the examination, and even our EDPM course also, most of the candidates have successfully cleared the examination this time, both part one and part two.
Okay, one is online, one part, and then the other part is directly in Belgium. Yeah. And
Yes,
again, the requirements still the same, 1 year experience as pain physician.
yes.
Okay, noted. Hopefully, Dr. Ira, if you still have an interest, you can join. Another questions about using secretum for the knee pain. Do you have any experience, doc, to using secretum and stem cells?
Okay, secretome not that much. I use more of PRPs and
PRP.
BMAC sometimes for the patients. But exosomes and secretomes not yet available over here. It is coming. It is coming. So
Oh,
once
it is coming. Okay.
I have that, then we can discuss on it.
Oh, okay. Dr. Fanny, Dr. Khaja prefer to use PRP rather than exosome or secretome. Okay, another questions, doctor, from Dr. Karuniawan. Hello, doctor. How are you, Dr. Karuniawan? Long time no see. For the one who has conventional RF, previously you talk about cool RF. How about the conventional, the hot one? How we can give the optimum result? How we select the patients and how we select the site of the knee region? So it's still talk about the conventional part, though.
Okay, so basically, when you're planning for conventional RF, then again, in my practice, I've seen even though theoretically the cool frequency ablation gives you better results and larger results, larger lesion, and the results also should be there. But conventional RFA also doesn't give very bad results. It is also a very good option for knee osteoarthritis patients. What happens is the most important thing is going to be the targets. So as you saw, I have entitled the newer targets, the newer advances in radiofrequency ablation, where all we have to target this to do the procedure. If you are hitting the right targets, then even with conventional RFA, you can get good results. For example, for superior geniculate now, you have to hit the adductor tubercle, right? So that is a good target to get good lesion, and IPBSM also pulse RFA will give you very good results. So it's all about hitting the right targets. If you are hitting the right targets, then definitely, if you're selecting the right sites, the right targets as I have shown in my presentation, then you should be able to get good results.
And is it correct that you mentioned before with hot RF or conventional one, you hit more targets compared to the cool one? Is that?
Yes, yes, Correct. Because the conventional one, you are targeting each nerve individually. Many of our time with cooled RF, you can just, it's a fatter needle. If you're thinking of a cooled RF, it's a more fatter needle and a little bit more painful compared to the conventional RF. So in many patients, I use the conventional RF instead of the cooled RF because it's more acceptable to the patients as well when you're doing the procedure. Because remember, you're doing it under local anesthesia and you have to try to make the experience as much comfortable to the patient as possible. So for that, you are individually targeting the specific nerve sites to get the right lesion and the right result.
Okay. How about that, Dr. Karuniawan? Shall we open again the photos about the targets? How we choose the targets? Or
Should we
is it?
again do it? You
Yeah,
want
I
me
think
to?
so. Yeah, I think so,
Yeah.
Doc. Yeah, maybe you can open again the picture, which part, which target is correct one, yeah, maybe.
Yeah. Just sharing my screen again.
Yeah, yeah, Doc. So Dr. Karuniawan could see again.
Superior
Okay.
middle genicular nerve. This is going to be the target. Okay. You can identify the rectal tubercle over there. Okay. And there your needle should be there. This is for superior middle genicular nerve. Inferior middle genicular nerve. This is going to be the target. Okay. Wherein you are advancing the needle, junction of shaft and condyle, close to the pulsation of the artery. Infrapatellar branch of saphenous nerve, again above the arterial tubercle only, but more in the subcutaneous plain region. You can identify it. Okay. Superior lateral genicular nerve, over here, you have to target. This is for the recurrent fibular nerve. Here, this was for the targets.
Yeah. How about that, Dr. Karuniawan? Any more questions? I will share the PowerPoint so you can have these targets as guidance. Small book. Any more? I remember there is a questions before about your course, Dr. Khaja. Could you
Yeah.
explain to us about Algo Spain course event and how much maybe the average and how many times you do it? Maybe you can explain more, Dr. Khaja.
Yeah, I'll just share my screen 1 second.
Okay. We are waiting Dr. Khaja's screen
Yeah.
because he will explain about his pain course and maybe everyone who would like to have FIPP or CIPS or maybe that Belgium Europe certification, you can have this pre-exam course with Dr. Khaja. It's
Just
located in Bangalore, yeah, Doc? Yeah.
yes, yes, correct.
From Bangalore, then how many hours flight from Mumbai?
Mumbai, it'll be like it'll be maybe 2 hours. Sorry,
Oh,
1 hour, 1 hour flight, 1 hour flight.
1 hour flight.
Yes, yes, 1 hour flight.
Okay, so Jakarta to Mumbai and then Mumbai to Bangalore, or maybe is there any from Singapore directly to Bangalore? I
Yeah,
have no
yeah,
idea.
you have direct flights
Oh,
to
direct
Bangalore.
flights from Singapore.
Yes, 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 we have.
Okay, nice, nice. So for all doctors here, maybe you can try to get from everywhere, wherever you are, catch on to Singapore, and then from Singapore, there's a direct flight to
Yeah,
Bangalore.
just sharing my screen now.
Yes, perfect, doc.
Okay. Hope my screen is visible. This is Algos Academy of Medicine. I'm the founder and director of the Algos Academy of Medicine. So we have a host of courses for our candidates. One is a FIPP preparatory course. This is a comprehensive course, right? So we have two modules in this. One is the online version, wherein we prepare the candidates, teach all the topics related to the FIPP examination, and we cover the entire syllabus in this. So it is an online course run through Zoom. We have almost two classes per week. Okay. And if anybody misses the classes, then recordings are also available. I have divided the entire course into modules. Okay. And after the completion of each module, we will be having one assessment, all on the lines of the FIPP examination. Okay. And we also have the optional offline module, wherein what we do is the candidates come and visit us at our facility, at our center over here in Bangalore, and we have a mannequin made from real bones on which they practice all the 20 procedures, and we make it like a mock examination for them, right? So that they are well prepared before they go and crack the FIPP examination. This is our success stories. Okay, you can see a few familiar faces also over here. We have doctors from Indonesia also who had attended the course and become successful, like Dr. Fajar and Dr. Rolando. Okay. This is the mannequin course, what I was talking of, the hands-on optional preparatory course. Okay. The specialty is we focus on just taking as much limited number of candidates as possible so that they get maximum exposure on practice. We also have the EDPM preparatory course, European Diploma in Pain Management, Part 1 and Part 2 preparatory course. Okay. And they are both online courses covering all the aspects of the examination for the EDPM examination by European Pain Federation. Again, this course is also divided into two different modules, almost four modules. At the end of each module, you're going to have an examination. It covers all the aspects of the examination. We also have mock exams also before the exam to help prepare you till the exam actually. This is our success stories from previous year. This year also we have had a lot of success stories. So we EDPM are two. One is by European Pain Federation and other is by European Society of Regional Anesthesiology. We prepare candidates for both. Okay. These are our success stories. We also do courses for undergraduate level also, or should I say postgraduate level actually, those entering into pain medicine. One is fundamentals of basics in pain medicine, wherein candidates come and they learn. It's also an online course, okay, wherein we teach tips to start pain practice, how to diagnose patient, how to look at as a basis of pain medicine. We also have anesthesia exam preparatory courses also, where we prepare the doctors for the anesthesiology examination. It's an online exam. Okay. So we have recently started from this year doing the ultrasound hands-on workshops as well. Okay, so this was our first module we did on the upper limb. Okay, we had a lot of delegates who had attended, and we have faculty demonstrations, hands-on volunteer scanning sessions, and then live procedures and cases also, wherein the candidates can see and get hands-on experience. This was done in April, and this was we just recently concluded in the month of December. Just past Sunday we did this, and this was all about ultrasound of the spine. Okay, where we had faculty demonstration, hands-on scanning on volunteers, and then live procedures as well. A new course has been added, that is a integrated palliative care course for doctors. Okay, wherein we teach them cancer pain and palliative care for the doctors. So this is about our courses. Stop sharing my screen. And we are starting new batches from next month, that is January, for all our courses. I'll request Carli to share the contact number. If anybody is interested, you're all welcome to come and join our courses. You're muted, Carli. Carli, you're muted.
Okay. I will share now to the doctors here. Any more questions, maybe? I'm sharing on the way to the WhatsApp group with Any more questions? You can also ask directly to Dr. Javed. So just raise your hand, maybe. Anyone who would like to ask? There's a questions, Dr. Khaja, about the price. Because we don't know what the FIPP. We know FIPP $2,500 US. How about the EDPM, doc? How much
Yes.
it take, doc?
EDPM comes at around part one exam comes at around 400 euros, 420 euros
400
something.
euros. Okay,
And
part one.
yeah, and part one. Part two comes close to around 700, 800 euros. I can share the exact details. If anybody wants, you can message me. I'll just share the information bulletin and the links as well.
I will share that +917975, that number, yeah, doc.
Yes, yes. 758 962 550. Yes.
Okay, 550. Okay, doc. So anyone who would like to ask directly. So do you think the EDPM is much cheaper than
Yes.
FIPP?
Yes, yes, much cheaper, and I would say it's a very good certification to have because part one is totally online. You can do it from the comfort of your home, okay? And part two, you will. But the thing is, it requires good preparation because passing percentage is more than 75%, right? So you need to be prepared well. You need to know the topics which are going to come. So we help candidates prepare for the EDPM examination, and once you have passed the part one, then you become eligible for the part two exam.
So passing grade EDPM greater than FIPP.
Yes,
Greater and much cheaper.
definitely.
Wow, wow, nice, nice. But good quality, right, though? Same quality, right?
Yes, yes.
Okay, okay. More questions, maybe? I already sent Dr. Khaja number and also flyers to the group. I asked my team to share it. Hopefully already been sent right now. Wow, I think we much cover all quicker than we thought. Hopefully, everyone's could get some insights, knowledge that Indonesians doctors like Dr. Khaja said, Dr. Fajar neurologist, Dr. Rolando orthopedics already successful, graduated from the FIPP and CIPS exam course from Dr. Khaja in Bangalore. Hopefully anyone can join. If join, don't forget my oleh-oleh and present for Dr. Khaja. Thank you so much, everyone.